Thank you, Mr. Chairman, and thank you very much for putting on this very important hearing. And thanks to all the witnesses. You folks have just done an outstanding job. This is other witnesses, the witnesses have stated before, and colleagues on the panel have stated, is a woman's health issue. But I think it's important to point out that it's also a community health issue. This is something that affects all of us, and the better handle we get, the more our entire community is going to benefit from this. A couple of witnesses, Dr. Liu, for sure, I think someone else mentioned it also, talked about the success that California has had. And I want to focus on it a little bit. We started making our progress, it was just in 2006 when we established the CMQCC. 7 years after that program was started, our maternal mortality rate in California was cut in half. 7 years cut in half. And that's pretty incredible if you think about that. The other thing is that the rest of the country, their rate skyrocketed during those same 7 years. So we've done well in California, but I think we have a long way to go. In particular, the gains that we've made in California haven't been shared equally. The mortality rate for African American mothers in California is still 3 or 4 times greater than it is for white women. Dr. Liu, what are some of the lessons Congress and other states could take from our experience in California, and how can we make sure the benefits of our efforts are equitable, that women of color are not left behind?
So yeah, I think first of all, the key lesson here is quality matters and safety matters. We were able to kind of really show that kind of result in California because we create a culture of quality and safety in hospitals throughout California. And that's kind of really the idea behind AIM is really try to spread that culture of safety across all birthing hospitals in the United States. I think the other kind of really important thing for Congress to be aware of is that it's about the social determinants of health. I think improving quality and safety of maternity care will get us halfway to zero maternal deaths. But if we truly want to eradicate maternal mortality in this country, we really have to work on improving the health of girls and women across their life course. And that has a lot to do with healthcare access, but that also has a lot to do with creating the kind of social conditions in which girls, women, and families could be healthy. And this is why I'm so excited that this committee is holding a hearing on this. It's because within your jurisdiction, you actually hold many of the levers that could really lift up children and families in this country.
Thank you very much. It's also clear that there's a link between social factors, unemployment, education level, income, social support, et cetera. In one of my counties, mothers without a high school degree experience higher rates of obesity, domestic violence, homelessness, food insecurity, and other related issues. Dr. Harris, what can healthcare providers be doing to better incorporate these social factors into their work?
I think we continue to do the work that we are currently doing at the AMA in partnership with United Healthcare, incentivizing physicians, developing diagnoses and codes that link higher reimbursement to address these issues. It's important to identify the issues, as you just mentioned, issues around lack of transportation, lack of access to healthy, nutritious foods, lack of access to a quality built environment. Those are all of the social determinants of health that do impact healthcare. Again, you and someone on the panel mentioned zip codes. And we know that we need to, again, address the quality and address healthcare, but 80% of what impacts health is beyond healthcare. And so we absolutely have to address those issues. And it is job training, it is workforce development, it is looking at the built environment, it is making sure that we don't have food deserts. So all of those issues are critical in addressing the social determinants of health. And then on the other side, we certainly have to start with our own implicit biases. We all have implicit biases. They are our blind spots. But first we have to name them, and then some of the training we will be doing at the AMA is to have folks name their own implicit biases and then move forward in how and knowing how that impacts care.
Thank you all very much.